All right, starting to get into the good stuff. All right, coronary artery disease truly affects over 7 million people a year. So coronary artery disease means when we have a blockage of the coronary arteries. Fortunately, whatever, men and women are affected equally, although their signs and symptoms can present a little bit differently when it comes to MI, and we'll talk about that. So what causes coronary heart disease or coronary artery disease? It's when you have atherosclerotic plaque in the coronary arteries, and that plaque impedes blood flow to the heart. Sometimes small occlusions, you can be asymptomatic. Sometimes it leads to angina or chest pain. If there's severe blockages, it will lead to a myocardial infarction, dysrhythmias, heart failure, and potentially even death. So, the pathophys of coronary artery disease. What happens is you have an injury to the arterial wall, which I kind of mentioned in the last podcast when we started talking about it. So you have an injury to the arterial wall. This can be due to high blood pressure, smoking. What happens after that injury occurs is you have your macrophages that begin to attach to the wall. Lipids can easily clump onto that. Cholesterol deposits collect over that. Remember the picture of the cheeseburgers and the fries? The lipids, cholesterol, it creates a wall, okay, or plaque, okay, is what it's called. When that plaque builds up so significantly and becomes so thick, it occludes the artery partially enough to cause ischemia, or maybe completely, in which you have infarction occur, okay? Now, there are different types of risk factors for coronary artery disease, okay? Some of the things that we can't change. We can't change our age, we can't change gender, we can't change our race, we certainly can't change our genetics, right? What do we know about these risk factors? Well, according to age, 50% of people who have CAD are over 65. 80% of the deaths are due to myocardial infarctions that occur in this age range. Okay, well, why is this important? Although we can't change the non-modifiable risk factors, we can teach prevention and recognition of the signs and symptoms. If we talk about age, typically men are affected at an earlier age than women, okay? The reason for that is estrogen. So statistically speaking, coronary artery disease appears in women after menopause, which really tells us that estrogen plays a role in reducing CAD risk, okay? It is believed in some studies that estrogen replacement therapy is actually correlated with lowering lipidemia. However, bigger red flag, estrogen therapy is also associated with cancer. So, again, not necessarily maybe the best choice. Now, risk factors that we can change. Modifiable risk factors, okay? We can quit smoking. We can eat better. We can exercise. Personality, what does that mean? Well, do you live a stressful life? Could stress be reduced from your job? Things like that. Diet, improve our cholesterol, right? Improve our HDL. Cigarette smoking is the leading independent risk factor for coronary artery disease, okay? Once a person stops smoking, the risk of dying from coronary artery disease is reduced by 50%. Now, pathologic conditions. Pathologic conditions contribute to coronary artery disease, okay? Diabetes. Diabetes is a risk factor because diabetics typically have higher lipid levels, higher blood pressure, increased weight. These all contribute to atherosclerosis by affecting the blood vessels, and platelet function is altered. Hypertension is another pathologic condition. We define hypertension control as maintaining a blood pressure less than 140/90. Metabolic syndrome. Metabolic syndrome consists of a group of metabolic risks that one person has. Metabolic syndrome consists of obesity, hypertension, and high blood sugar. Another pathological condition would be, for women, early menopause. Another pathological condition is hyperlipidemia. We might need drug therapy to lower our LDL and raise our HDL. Some of the drugs that we might take to lower our total cholesterol are called HMG-CoA reduction inhibitors. Those are our statin drugs, okay? So tuck that knowledge away for the farm day when we talk about it, okay? Next thing on the list is angina. So when CAD, your coronary artery disease, progresses, okay, you can develop angina. Angina is chest pain that is related to decreased coronary blood flow that causes an imbalance between your oxygen supply and demand, okay? The myocardium uses lots of oxygen from the blood supply. When the demand goes up, the needs go up, okay? Symptoms of angina include chest pain, shortness of breath, pallor, and anxiety. Anxiety more because you can't breathe and you're having chest pain. So what can cause angina? Atherosclerosis, coronary artery disease, exercise, stress, cocaine, other drugs, heart failure, okay? The major symptom of angina is chest pain, okay? It is chest pain that's usually brought on by an identifiable event. So that's your patient that can sit and say, yep, I had chest pain, and I had chest pain after I mowed the grass. But then as soon as I sat down, my chest pain went away, okay? Pain, in addition to the chest, can also radiate to the jaw, the neck, and the back. So what relieves angina? We hope that rest, repositioning, and potentially medications like nitroglycerin will relieve angina. The classic sequence for angina is pain, rest, and relief. Okay? There are different types of angina. We're going to talk about that on this slide. So, stable angina, okay? Stable angina is the type of angina that is predictable, and it is always relieved by rest and nitrates, okay? Always. If you have unstable angina, it occurs with increasing frequency, increasing severity. It can even occur at rest, and it is typically not relieved by nitrates. Okay? You will often see unstable angina as an admitting diagnosis for a tele patient. When you have unstable angina, it can be indicative that you are beginning down the path of a myocardial infarction. Unstable angina indicates that there is definitely not enough oxygen supplied to the heart muscle, and we need to restore blood flow. There's a third type of angina called Prinzmetal's angina. That is unpredictable. It can occur at any time, and it may not be related necessarily to atherosclerosis or CAD, right? It might just be related to coronary spasms, so it's very unpredictable, okay? How do you know that you have angina? Physician's going to do an assessment, history, lab tests, diagnostic tests, EKG, stress test, echo, TEE, okay? All right, so up to this point, we've talked about coronary artery disease. Coronary artery disease is on a scale, right? It can be minimal, it can be significant, okay? If we go towards the moderate or the significant, that coronary artery disease can lead to our angina symptoms, which is what we just talked about. If we have chest pain associated with positive lab results, associated with positive EKG that shows a myocardial infarction, we need to take this patient to the cath lab and we need to have an intervention, right? Or first diagnose and then have an intervention. So a cardiac cath with a coronary angioplasty. Okay, so we talked about a cardiac cath, which is where we go through the groin or the radial artery and we insert that catheter all the way up into the heart and we inject dye to see if our arteries truly open up, right? Okay, well, if you look at this picture here, you can see that artery on the right-hand side, right? When you have just the plaque buildup on the wall here, hopefully you can see my mouse moving. See this plaque buildup? Okay, so this plaque buildup is occluding blood flow. So the angioplasty is the part of this procedure where we go in, it's a balloon, okay? This balloon, we place it right between the plaque and we inflate it and deflate it, inflate it and deflate it. And the goal is to push the plaque against the wall, okay? Enough so that we can place a stent in here that will keep the plaque pushed against the wall, and that stent will allow for clear, easy blood flow through the artery and restore that oxygenation in the blood flow, okay? The ultimate goal for these patients is to make sure that their hearts are getting enough oxygen and to restore the blood flow, okay? Let's see. Here's just another picture of the heart. You can see here, if you're looking, again, I hope you can see my mouse moving. Look here, this is a major occlusion right here of the LAD. This one right here in your right coronary artery, these bottom arteries are not being fed, okay? This is just another picture showing you the coronary circulation. Medications that we might use, nitroglycerin. Remember, and again we'll talk about this in pharm, but remember that nitroglycerin is a very potent vasodilator. So nitroglycerin is going to open up your arteries and help to restore the blood flow that we can until we fix the blockage, right? Beta blockers, they reduce the workload of the heart by reducing our blood pressure and our heart rate. Calcium channel blockers slow down the heart rate, right? So we have plenty of time for ventricular filling. Oral antiplatelet drugs. Some of the ones that we might choose truly is heparin. Heparin's probably the most common that we use before a cardiac cath. You know, if you think about placing a stent, okay, with a cardiac cath, that restoration of blood flow is important, but some of the things that we watch for afterwards, you want to make sure that we watch for chest pain afterwards. And sometimes we have what's called reperfusion, VTAC, which means that the electrical conduction system is trying to readapt to the new blood flow that's there. And so we'll talk about in class what to do for that reperfusion VTAC, okay? The other thing that you want to keep a close assessment eye on is their chest pain and their vital signs, because it can happen where stents, fresh stents, become occluded, and that is not an ideal situation for a patient to be in. Sometimes post-op cardiac cath patients are placed on Plavix for 1 to 2 years. Plavix, being an antiplatelet, will help keep the platelets from sticking together and sticking to the wall of the stent. Okay, let's say that, well, you know what, it's going to cut me off here, so I'm going to stop this one, and then we'll start with cabbage on the next one.